Welcome to the first lecture in the Navigating Paediatric Palliative Care e-learning series, an introduction to paediatric palliative care. This lecture will briefly examine what is paediatric palliative care and who might need it, what are the similarities and differences between palliative care in adult and paediatric populations, what are the models or principles of care employed in paediatric palliative care, who might be involved in providing paediatric palliative care, and what different settings might paediatric palliative care services be provided in? Firstly, we'll look at defining paediatric palliative care. Here, it is important to look more broadly at the general definition of palliative care before applying this more specifically to paediatric populations. Palliative care is defined by the World Health Organization as an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other physical, psychosocial, and spiritual problems. Paediatric palliative care, then, is recognised by the World Health Organization as a specialised sub-branch of adult palliative care for children who have a life-limiting illness for whom the primary treatment goal is to maximise quality of life, and is defined as the total care of the child's body, mind and spirit, which also involves giving support to the family. It begins when illness is diagnosed and continues regardless of whether or not a child receives treatment directed at the disease. Here, the role of health providers is emphasised in evaluating and alleviating a child's physical, psychological and social distress as part of a broad multidisciplinary approach that includes the family and makes use of available community resources, with care provided in tertiary care facilities, in community health centres and in family homes. So, who might need paediatric palliative care? Essentially, any child with a life-limiting or life-threatening condition that is expected to lead to an early death can and likely will access palliative care services. Here, life-limiting or life-threatening conditions can be defined broadly into four categories. The first is life-threatening conditions for which curative treatment may be feasible but can fail, such as cancer or irreversible organ failures. Here, access to palliative care services may be necessary when the treatment fails or during an acute crisis, regardless of how imminent death is, and when curative treatment is successful, there is no longer a need for palliative care services. The second looks at conditions where premature death is inevitable, as in cystic fibrosis or Duchenne muscular dystrophy. Here, palliative treatment can be and is often included from the outset, in combination with intensive treatment aimed at prolonging life and maximising participation. The third category relates to progressive conditions without curative treatment options. Here, palliative treatment is the only option and may commonly extend over many years. The fourth and final category relates to irreversible but non-progressive conditions causing severe disability, leading to susceptibility to health complications and likelihood of premature death, like in children with multiple disabilities, brain injury, or severe cerebral palsy. Here, palliative treatment is most commonly engaged when the child nears the end-of-life phase. So, how does end-of-life care differ when it comes to working with children and teenagers rather than adults, if at all? Well, as with adult populations, the primary goal of paediatric palliative care is to relieve pain and other symptoms, provide comfort, and improve quality of life. Also, palliative care can be provided along with curative treatment in both populations. This, though, is usually more common in paediatric populations because there is often greater uncertainty about the child's prognosis. In both populations, the wider team assists with decision-making and setting care goals, and a wide range of professionals are involved in providing care services. However, that said, there are special, fundamental considerations when caring for children, in that services must embrace the whole family as well as the child, involve health professionals with specialised skills in the care of children, support families as they care for their sick child and, where applicable, their other children, and understand the different responses children have to symptoms and their treatments. Note that the differences between paediatric and adult palliative care services are further explored in the subsequent reading for this module, but generally, palliative care for children is different from adult palliative care in a number of significant ways. Firstly, the number of children who die is relatively small compared with the number of adults, and furthermore, the death of a child challenges our norms and expectations, as children aren't supposed to die. This can make service provision more challenging for both service providers and recipients of services. Secondly, many of the conditions encountered in paediatric palliative care are rare, with diagnoses specific to childhood, although the child may survive into early adulthood and can be genetic, meaning that other children in the family may also be affected. Thirdly, the timescale of childhood illness is generally different from adults, so palliative care may only last a few days, weeks, or months, or may be delivered on and off for a number of years. In adults, however, palliative care services are generally only provided after shorter periods at the critical end-of-life stage, when avenues for curative treatments are exhausted. Another difference is that children's palliative care, at its core, formally embraces and encompasses the whole family, both as providers and recipients of care. An additional consideration is the continuing physical, emotional, and cognitive development that occurs throughout childhood, and awareness of the need to respond to each child's changing levels of communication skills. Also, education and play-based interventions are fundamental to service provision when working with dying children. This includes an additional care dimension and extra service providers like teachers, play therapists, child life therapists, or child behavioural specialists, which adds to the complexity of care provision. A final consideration is that medical decisions for young children are usually made by their caregivers, where adult patients are often in charge of making their own decisions. Here, the developing nature of maturity and autonomy raises separate ethical issues in questioning the competency of children when it comes to end-of-life decision-making. So, in light of these differences, how specifically do we provide care to paediatric palliative care patients? No one model of care is used uniformly across the country due to the high level of variability across service settings in Australia. It is widely accepted in the literature, however, that an integrative palliative and curative treatment approach is critical when working with children with life-limiting illnesses, as prognosis is often uncertain. This involves commencing palliative care at the onset of the condition and continuing throughout its duration, meaning that whether the outcome leads to cure or death, families are prepared for the worst whilst supported to hope for the best. In Australia, a paediatric palliative care service model review commissioned by the Australian Government Department of Health and Ageing was conducted in 2004. At the conclusion of the review, the authors highlighted a need for the implementation of a model of care that provides for an accessible, integrated, interdisciplinary approach based on principles such as respect for the dignity of patients and their families, access to competent and compassionate palliative care, support for the caregivers, improved professional and social support for paediatric palliative care, and continued improvement of paediatric palliative care through research and education. In their literature review, the project authors identified an ideal conceptual model for providing paediatric palliative care services, uniting curative and palliative approaches that is schematically presented here. This model focuses on meeting the needs of children, families, and communities by integrating all aspects of care under unified goals and offering interdisciplinary, holistic services. Looking at the model, the spiritual, medical, and psychosocial needs of the child, family, and community are at the centre. These are supported by interdisciplinary services, such as the medical team, counselling, allied health, and complementary therapies, which are provided across a range of care settings, such as at the home, in a community-based facility, or in a hospital, along a continuum, from the time of diagnosis to acute, chronic and terminal care, and also in bereavement. This support occurs within the context of a cycle of ongoing education, advocacy, research, and quality outcomes. Key elements of the program are tailored to meet the needs of the child and family, with packages of care being added or removed according to the changes in the child's condition. There is no single care delivery model that will work across all communities. Instead, the model should take into account the availability of existing resources and programs, avoid duplicating services, and build on what is currently available. Now, in line with this integrative model of care, we'll look at who is involved in providing palliative care services to paediatric populations. Typically, the parent or guardian is the primary carer, and they are guided, supported, and educated by a wider team. The members of a care team will depend on the child's and family's needs. Here, a multidisciplinary approach is critical in maximising duration and quality of life. The team is often managed by a key coordinator, whose role it is to work with the family to plan, coordinate, and communicate the care provided by different members of the wider team across agencies and disciplines. The coordinator may be a social worker, nurse, doctor, or member of the allied health team, depending on the needs and preferences of the family. Typically, the wider paediatric palliative care team can include medical professionals such as doctors, specialists, surgeons, nurses, and pharmacists, allied health practitioners like dietitians, social workers, speech pathologists, occupational therapists, physiotherapists, and Aboriginal and Torres Strait Islander health workers, behavioural therapists like child behavioural specialists, counsellors, and child psychologists, complementary therapists like teachers, art therapists, music therapists, massage therapists, and play therapists, and pastoral carers like chaplains, priests, and rabbis. Few, all, or a combination of these professionals will be involved in providing palliative care services to children at the end of life stage and their families. What's important is that all members of the team work together, each utilising and integrating their own specialist skills and knowledge in pursuit of the achievement of a common goal: improved quality of life through addressing the child's social, spiritual, physical, social, and cultural needs. Finally, we will discuss where paediatric palliative care services can be provided. Service settings most commonly utilised by children and families at the end of life include hospitals, hospices, community centres, outpatient clinics, and in-home care. Generally speaking, the service setting will depend on the nature of the child's condition and the stage of illness, and ultimately is dependent on patient and family preferences. Accordingly, it is not uncommon for children to transition between different settings, utilising each for a particular issue or set periods of time. Here, it is imperative that the overarching service system is responsive and dynamic to ensure that the transition is as seamless as possible. Given the demanding nature of in-home care, some caregivers prefer for their child to receive support within a hospital setting. This is particularly common in the case of children who have spent extensive periods of time in hospital, where the staff are familiar with the needs and preferences of the child and their family, or when the families lack external supports. Whilst tertiary paediatric centres don't commonly encourage patients and families to become dependent on the hospital system, it can provide better care provision options to some. To avoid hospital dependency, the child's GP or local paediatrician is generally involved as early on as possible, and early referrals are made to community-based providers. This allows the establishment and ongoing maintenance of a strong and supportive therapeutic relationship, meaning that in-home care is often a viable avenue by the time it comes to the critical end-of-life stage. Additionally, the research highlights that children's hospices are primarily used for respite and not terminal care. Of the variety of care settings available to palliative children and families, though, it is in-home care that is used most frequently, especially in the final stages, to maximise the child's comfort and quality of life. Providing in-home care, in consultation with community-based services, enables the parents or caregivers to feel more in control and allows children to be at home among their own toys, pets, family members, and friends. In-home care is advantageous in that families feel more secure in a familiar environment, privacy is greater than in a hospital or hospice, and the inclusion of siblings and extended family members or friends is easier facilitated, often to a greater extent than hospital routines allow. However, in-home care is not without its challenges, particularly in the case of slowly progressive conditions. Here, parents are tasked with adopting a nursing role, administering medications, managing equipment, and providing round-the-clock care in an exhaustive, anxious, and often financially draining balancing act. Many parents, though, find this a rewarding experience and are able to take comfort in their role in supporting their child through the final stages of their journey, which, in turn, can help them grieve after the child dies. More of that, though, in the next lecture in the Navigating Paediatric Palliative Care e-learning series.